Thank you, Dr. Larson. It's a pleasure to be here this morning, and I really do appreciate the opportunity and invitation from the Purina Institute. So I'm the cardiologist who's really the lead-in guy for the next two speakers who will talk about nutrition, which is why you're all here. What I hope to do is to give you a high-level view of myxomatous mitral valve disease in the dog, which is the most important heart disease in veterinary medicine. These are my disclosures. So my topics are going to be an overview of the disease. And I'm going to spend about half of the time with this overview because I think it talks about how we evaluate and diagnose patients who might have valvular heart disease. I'll talk about staging using the ACVIM categorization. I'll give a very high-level view of the drugs we use to treat myxomatous valve disease in dogs. I'll then talk more specifically about the therapy of asymptomatic or preclinical mitral valve disease, which is a very important topic, I think, for practicing veterinarians especially. And lastly, therapy of heart failure, both in the hospital and home. So let's begin with Ollie. Oliver is an 8-year-old male castrated Cavalier King Charles Spaniel who was presented to us for an asymptomatic heart murmur. This is a very healthy dog with tremendous exercise capacity. His only respiratory signs are those of a Cavalier. He snores when he sleeps, which makes it easy to take his respiratory rate, by the way. The main feature of his examination was that he had a prominent murmur. It was about a grade 3 to 4, radiated well, and was heard loudest over the left apex. And this is quite typical of myxomatous mitral valve disease. He was normotensive. We did not measure a natriuretic peptide since we were going right to echocardiography. And as you'll see, his echo showed evidence of degenerative or myxomatous valvular disease. These were his baseline x-rays, and I think you can appreciate that at least subjectively it looks like he has some cardiomegaly. His left auricle seems a little bit prominent on the VD. On the lateral, his heart seems generous, but when you do a vertebral heart score or sum or size, whatever you prefer in terms of that term, by measuring the width and the length or height of his cardiac silhouette and comparing it to vertebral bodies, he kind of still falls within the normal range for Cavaliers, although subjectively to me he does have cardiomegaly. We also looked at his vertebral left atrial size, and that's done by measuring from the dorsal border of the caudal vena cava to the carina, and also comparing it to vertebral bodies, starting with T4, and that was actually within normal limits. Some of you, especially the internists, remember going, what's going on with the biliary tree? And all I could say about that is, today I'm a cardiologist, so I don't care. Okay, he was not symptomatic. But some internists just study Cavaliers. I've seen, maybe because I have a bias for seeing Cavaliers, but they get cholangitis and other related things, mucoceles, I think. All right, in terms of myxomatous valve disease, this is what we're seeing with Ollie. And I think you can appreciate there is prolapse of the mitral valve, which is the lower arrow, and the tricuspid valve as well, which is why I actually prefer the term myxomatous valve disease as opposed to myxomatous mitral valve disease, but I'm not going to change what we call it, so I'll probably call it both this morning. You can see on the right, there's an eccentric jet of mitral regurgitation encoded in green, the typical eccentric jet that we see with primary valve disease. And at least subjectively, his left atrium looks like it's remodeled, at least mildly, and he also seems to have some LV dilation, but that would need to be measured. So what is his disease? This is not Ollie, fortunately, but what we know is that if we look at the atrial perspective on the upper image and on the open atrium and ventricle in the lower image, that this is a degenerative disorder and has been well characterized by a number of pathologists, including Whitney back in the 60s. It's characterized by nodular thickening of the mitral and usually tricuspid valves. The endocardium is smooth and glistening, so this is not an inflammation. The pathologist called it endocardiosis, I think probably to emphasize it was not an inflammation. The leaflets usually appear somewhat expansive at autopsy, and they certainly do by 2D echo. We often see ruptured chorda tendinae, and histologically, the main abnormality is myxomatous change, deposition typically of proteoglycans, and I'll show you a histology of that in a moment. So this is a nice slide courtesy of Phil Fox, and on your left you see the normal valve and its 4 layers. In the center is an H&E that shows expansion of the central layers, the spongiosa and fibrosa, with it mostly a cellular material. And these are the proteoglycans, we used to call them acid-staining mucopolysaccharides, that tend to infiltrate these layers of the valve. And on the right, there's a trichome stain that is showing disruption of the fibrous tissue that would normally be present, especially in the fibrosa of the mitral valve. And so this is a degenerative change, and it's pretty well characterized, I think, by many pathologists. Now, in addition to pathology of the valve, we have other imaging targets. So on the left, you can see a good example from the atrial perspective of myxomatous change, and you can see there's a ruptured cord of the anterior leaflet. In the center, we see at least 3 abnormalities. So we see marked dilation or eccentric hypertrophy of the left ventricle. The left atrium is extremely dilated. And of course, we're going to use this to classify and stage the severity of the disease. And this dog died spontaneously from a ruptured left atrium. Both the left atrial wall can rupture, causing hemopericardium, or we can also see rupture of the atrial septum, causing an acquired atrial septal defect, which actually probably helps most dogs. On the right is just an example clinically from a different dog, and you can see highly echogenic effusion in the pericardial space in this off-angle 2D image. These dogs usually present with softer murmurs, hypotension, and a history of collapse. And this is from spontaneous rupture of the left atrium, something Jim Buchanan talked about in the 60s. Now, if we think about the pathogenesis of this disease, there are some excellent reviews in the references and also shown on this slide. What we know is that there are clear genetic predispositions, age predispositions, breed predispositions, and probably sex within certain breeds predispositions to developing this disorder. The valve interstitial cells and endothelial cells or endocardial cells of the valve play a role, and they alter signaling. Probably the most prominent signal abnormality is thought to be increase in serotoninogenic signaling. Anybody who's old enough to remember the diet drug fen-phen will know that it was serotoninogenic, and people would develop myxomatous mitral valve disease. And when they stopped the drug, many people actually reversed, which was great. But the problem with serotonin is it's hard to block it without having a lot of side effects. And so currently, while this remains an area of active research, we still don't have a treatment to really modify this signaling. There are other signals, metalloproteinases, perhaps even angiotensin II, that are also potentially influential. An increase in the proteoglycan deposition within the valve, this leads to disruption of the collagen and fibrous tissue within the stroma, and we get mitral regurgitation and tricuspid regurgitation. Very commonly, we'll see in the clinic a patient who's suddenly decompensated, and this is a patient who's developed acute congestive failure due to ruptured cord tendony. You can see on the left, this is the same patient, by the way, myxomatous change in the upper arrows, and in the lower arrow, you can see the ruptured cord. And you can see a flail leaflet. It's an apical view on the right on the 2D echo, and you can see the left atrium on the bottom, and the mitral valve is flipping back into the left atrium, and then it's literally everting out towards the aortic valve and diastole, and that's a slam dunk for a flail leaflet. Also notice the size of the heart. This is a chronic disease, and look how hyperdynamic the left ventricle is. Many dogs express this degree of hyperdynamic change. So in terms of the clinical presentation, this disease has been well known for over 50 years, really longer. And what we know is that there are certain breed predispositions, but in general, this is a disease of smaller breed, middle-aged to older dogs. Now, large breed dogs are affected by valvular degeneration. They usually present in a slightly different way. Their valves are less thick. They have greater tendency towards myocardial dysfunction. But the vast majority of dogs that we see are small breeds. Now, it's estimated that about 10% of the patients seen in a small animal practice probably have this disease, these canine patients. And it accounts for the vast majority of heart disease that we see in dogs. I'll show you that some examples of typical breeds, but this is only a very short list. This is an extensive list if you look at tables. Everyone knows about the Cavalier King Charles Spaniel, getting it often at a very early age. And if you go to a Cavalier show and listen to dogs, you'll often hear systolic clicks in 2-year-old dogs, which is really a sign of developing myxomatous mitral valve disease. There are many other breeds that are affected: Chihuahuas, Dachshunds, Shih Tzus, Maltese, and the list goes on. And some of it's probably regional, depending on preference and genetics. Fortunately, We can diagnose this pretty easily if you can take your stethoscope out of your pocket. I know most of my vet students now really just want to have an ultrasound probe in their pocket, but I think that it's still helpful to take your stethoscope out. If you look at the bottom image, that is a prolapsing septal tricuspid leaflet, and that can lead to clicks, as can, of course, mitral valve prolapse. And if you look at the phonocardiogram above it, you can see clicks that are between the first and second heart sound. So they are systolic clicks, but they are moving throughout the cardiac cycle a bit, and even going away at times. Of course, eventually, this gives way to the typical systolic murmur, which may begin as a decrescendo murmur, but usually becomes holosystolic and largely obscures the heart sounds over time. We often hear murmurs prominently on the right, and these can either be radiating from the mitral valve or they can be separate murmurs of TR. And if you have pulmonary hypertension, it's been shown that you often have a greater tendency to a louder and louder murmur on the right if there's pulmonary hypertension coexisting. In terms of auscultation, then, we have numerous papers showing the correlation, if you will, between auscultation and Doppler echocardiography. Auscultation is a very effective way, even for beginners, to recognize this disease. We do have evidence, both clinical and some research, that the intensity of the murmur in general correlates to severity of disease, at least in the small breed dog. And by that I mean if you have a very focal, soft murmur, it's pretty likely this is early or mild mitral regurgitation. If you have a very, very loud murmur with a precordial thrill, you almost certainly will have significant remodeling of the heart. The middle murmurs, the ones that do radiate but are more moderate, some of those dogs have minimal remodeling, some of them are in congestive heart failure. So it's probably a little more challenging to sort that group out. There's a lot of overlap if you look at some of the studies. And one point I always make to practicing veterinarians is you have to have a heart disease before you can have heart failure. And you have to be able to define that heart disease. Well, what heart disease do little old dogs get? They get myxomatous mitral valve disease. They ought to have a murmur. So when patients present with respiratory signs and they're little small dogs and they're older, if you're going to diagnose congestive failure, they either have myxomatous disease and need to have a murmur, or else you better do an echo and figure out they have something else going on. Most of those dogs have primary respiratory disease, as I think most of you in the audience already know. Now, this is a vet student's dog with x-rays taken over about a 2-year period. And what we can see is there's a very slow progression from the initial finding of a soft murmur to a louder murmur. And over time, we usually see progressive remodeling, or enlargement, if you will, of the left side of the heart, and to a varying degree, the right side, although it's often underwhelming. What we can also see is that it can take 4 or 5 years before the first identification of a soft murmur before you see a dog develop signs of heart failure. And so this is a disease that you don't want to intervene with too early unless you know you can somehow delay the progression of disease, which right now is kind of up in the air. And what we usually look for is a rapid increase in heart size in the 6 months prior to the development of heart failure. And as I'll show you some data from Peter Lord from the EPIC study, this is a pretty good way for veterinarians who can't do echo to try to follow their patients and help gauge risk. Now, to confirm the diagnosis, you need echocardiography. And here you can see myxomatous mitral valve disease. You can see thickened mitral valves. You can actually see a ruptured chordate tendony at the little asterisk at the bottom left. You can see a jet of mitral regurgitation going through the regurgitant orifice there. And so Doppler echocardiography allows us to see the regurgitation, and 2D or M-mode echocardiography allows us to quantify the remodeling of the heart that's occurred due to chronic valve leakage. The image on the right is a spectral Doppler. Those who don't do Doppler, this is simply a quantification of the velocity of flow and the timing of the flow in systole and diastole across the mitral orifice. Dogs typically have very high velocity MR because they have a great pressure difference between their left ventricle and left atrium. So for patients with systemic hypertension, for example, the murmur often tends to get louder because you increase the left ventricular pressure. And in patients who are hypotensive, let's say from rupturing the left atrium, the murmur is often softer because the gradient between the left ventricle and the left atrium has been diminished. Now, this is a somewhat complicated slide, and we could easily spend an hour just in this slide. If you go to your physician with mitral valve disease and they're trying to decide how bad it is, they're going to be focused on Doppler imaging. They will certainly look at the valve, they will look for remodeling, but they want to fix your valve before your heart's remodeled too much and you go into heart failure, because otherwise you may not do so well. However, currently, because we have limited options for valve surgery, we don't really dwell too much on color Doppler. But this will change in the future, because as devices become available and perhaps more centers do surgery, then it will be important to try to stage disease not just by remodeling or changes in heart size, but also by changes in the volume of blood going back into the left atrium. So on the left, you can see a mitral regurgitant jet. There's a very wide regurgitant orifice, or what we call vena contracta, at the star. In the center, we're looking at the three components of a mitral regurgitant jet. So blood from the left ventricle, which is coded in dark blue at the top, is moving towards the mitral orifice. Because we've shifted the color baseline down, you can see we've shifted it down to, I believe, 29 centimeters per second. The red cells cannot be faithfully recorded in terms of their velocity. So they alias, and they create a hemisphere. That yellow hemisphere you're seeing is called the proximal isovelocity area. All those red cells are moving at about the same velocity. And then if we know the distance between that hemisphere and the valve orifice itself, you can actually calculate flow rates through the valve regurgitant orifice area. And these are things that are very important in people, and I think will become increasingly important in dogs if we develop the devices and an economical way of delivering them to more patients. On the right, you can see a diastolic flow pattern, and this is what cardiologists use to try to assess diastolic function and especially filling pressures. The one caveat I would say for anybody doing Doppler is mitral regurgitation is not the same as regular old heart failure, because you artificially elevate the left atrial pressure at the end of systole. It's called a V wave on a hemodynamic tracing, and that artificially raises the pressure at the very end of systole, so as a result, the blood rushes forward into the ventricle and diastole very rapidly, which is what we're seeing here, a tall early filling or E wave on a very small atrial wave. This usually indicates high pressure and poor compliance or high stiffness of the left ventricle. But what we know is that it's challenging sometimes to diagnose congestive failure just from Doppler. We've tried and not always been able to do it. So you still need to do a clinical exam. The other thing that's really common that we see with Doppler is evidence of pulmonary hypertension. Now, pulmonary hypertension, or increased pressure in the pulmonary artery, is usually diagnosed non-invasively by measuring the velocity of the tricuspid regurgitant jet if you can align to it. Now, the problem is we rarely, if ever, catheterize patients, so we don't have a gold standard for pulmonary artery pressure. And if you look at some of the human literature, it's not a very good correlation many times between the Doppler estimate and the actual measured pressure. This is a study from Alfort, and this just shows you, I think, the complicated aspects of pulmonary hypertension here. So if you look on the x-axis, that is the pulmonary artery pressure estimated by Doppler. Now, if you look on the y-axis, they measured the ratio of the left atrium to the aorta, I think trying to show that there would be a correlation between the size of the left heart and the degree of pulmonary hypertension. But as you can see, this is a pretty meager correlation. Look at the scatter across there. The standard error of the estimate is really high. The R-square, which shows sort of shared variability, is close to 20%. So 80% of the pulmonary hypertension in this cannot be explained by the left atrial size, if you will. And that makes sense to me, because this is way more complicated. So firstly, this is a recording of a Doppler recording across a ruptured atrial septum. It's actually a treatment that's now being used to treat dogs with advanced mitral valve disease to decompress their left atrium. And what you see is a peak velocity that is estimated at 65 millimeters of mercury. That suggests that the left atrial pressure is about 6 times higher in this dog at the end of systole than it should be. This is a tremendous increase in pressure. Now, if you look at Mr. Hands here, if this is your left atrial pressure, this is your normal pulmonary artery pressure in dog, right about 20/10. Well, what happens if you raise the pressure in the left atrium, by 50 or 60 millimeters of mercury? You get pulmonary hypertension, right? And this is the classic class or type 2 pulmonary hypertension of left heart disease. The problem is dogs can also have pulmonary hypertension from pulmonary vascular reactivity or disease, from chronic lung disease, or from diagnose pulmonary emboli. So there are other reasons, so-called pre-capillary reasons, if you will, to get pulmonary hypertension. The reason this is important is because we don't treat every dog with pulmonary hypertension with sildenafil. That would probably be a big mistake. And so it's important to have an idea of why a patient might have pulmonary hypertension. And you can also see that the LA doesn't correlate to this very well, which makes sense to me because it's not all post-capillary. It's not all due to left heart failure. Plus, the LA is a bad measurement for that. What about systolic function? Ventricular systolic function is almost always hyperdynamic in small breed dogs, not necessarily in large breeds. We often will see with chronic MR a cardiomyopathy of overload or else a concurrent DCM. I don't think we know for sure. But in small breeds, invariably you see hyperdynamic function in almost every detailed study that you do. On the left is something called global strain. Global strain is a way of measuring deformation in the apical basilar direction. And you can see there are 6 curves there of color that correspond to the segments, and then a dotted white line, which is the global strain. Normal peak global strain is about -17. It's about -34 in this dog. It's twice normal. In the center, you see a short axis image of the left ventricle with a similar kind of technology, but now we're looking at radial strain, how the ventricle contracts inward or deforms inward. And normally it would be maybe 40. It's almost double in this dog. And even the right ventricle is hard to assess. This is a nice 3D reconstruction that Emily Chapel did in our lab. And what you can see is the tricuspid valve on the top left, the pulmonary valve on the top right. And you can see how the right ventricle has a sort of a U shape and contracts very vigorously in an apical basilar direction. Well, part of this is because the septum is tethered to the left ventricle. So if the left ventricle is hyperdynamic, the right ventricle is often hyperdynamic as well. Most of the time, you can't even show impaired function with these advanced studies until a patient is in congestive heart failure. And personally, I don't think I need that kind of study to tell me a patient's in congestive heart failure. It's too late to be useful at that time. All right. Now, the one thing I'll say is, because this is something where I would, I guess, vigorously disagree with much of the literature. Most people started out doing M-mode. I certainly did. And we would measure the left ventricular diastolic and systolic dimension. Well, then what happened was people started estimating volumes from these minor dimensions. And in a healthy dog, you can do that fairly well. But once a ventricle starts to dilate, minor dimensions grossly overestimate the volumes in the left ventricle. It's been shown by a number of studies. And as a result, just because you have an increased end systolic volume index measured by M-mode, it does not necessarily mean you have impaired heart function. And so I think that the idea that we can readily identify abnormal heart function in primary mitral valve disease is a little bit of an unproven statement, at least to my mind. What about the ECG? I mean, when I started practicing, what we did was we listened to a patient, we did a chest x-ray, and we did an ECG. There's nothing wrong with doing an ECG, but if a patient auscultates in sinus rhythm, it's unlikely you're going to find very much useful. You may see changes in the P waves or QRSs that suggest remodeling. I think in the future, when we get artificial intelligence algorithms that are good for dogs and that actually where ECGs are recorded in a standard way with proper filtering, that there may be information in there that we don't know about and we will find out about. And I think that's something that would be an active area for research for people interested in EKGs. Holter monitors are not routinely done in small breed dogs with mitral valve disease unless you hear an arrhythmia or you discover one on a routine EKG. But certainly there's evidence that 24-hour monitoring and advanced analysis can show changes in autonomic balance. As many of you probably know, as heart failure develops, you tend to withdraw your parasympathetic and increase your sympathetic tone. And this can be shown by things like heart rate turbulence or heart rate variability, but this is not a standard of care even among cardiologists today. Blood pressure, though, is, because we know that the higher the pressure in the aorta, the more mitral regurgitation you're likely to get because you increase the left ventricular to left atrial pressure gradient. Additionally, really severe elevations in blood pressure impair cardiac function. it's very complicated to measure afterload, and blood pressure is not the same as afterload. But in general, if you have a higher blood pressure, you're probably going to impair forward flow out of the LV. So we routinely measure blood pressure in our chronic mitral valve dogs. And since many of them have comorbidities like chronic kidney disease or Cushing's and have higher risk for high blood pressure, it makes sense to screen for hypertension in patients with cardiac murmurs due to myxomatous valve disease. In terms of therapeutic implications, ACE inhibitors could certainly have a modest effect on blood pressure. And we know that if you have significant hypertension or if you have decompensating heart failure and you're still normotensive, that getting the blood pressure down may actually improve in some patients their cardiac function and improve their heart failure. So drugs like amlodipine and still hydralazine and occasionally more aggressive drugs like nitroprusside are used in intensive care units for patients with severe decompensating mitral valve disease and life-threatening pulmonary edema. Now, the natriuretic peptides are certainly very interesting, and the heart is an endocrine organ, right? Somebody won the Nobel Prize for that. And what we know is if you stretch the left atrium or the left ventricle, that you'll increase the release of A-type or B-type natriuretic peptides. These hormones are fundamentally the opposite of the renin-angiotensin-aldosterone system, right? They're natriuretic, they're vasodilatory, and they're also antifibrotic. So these hormones are released as a natural response to dilation of the chamber. We use them as biomarkers. I think you can see, if you look at this diagram from Jack, that when there's stretch on the left heart, that you're going to increase formation of the prohormone of B-type natriuretic peptide, or BMP. And then what we know is that prohormone is released in the blood. It's split by an enzyme such as chorin or furin into an inactive fragment, which is what we measure. So when IDEXX measures this, currently they're the only ones who really do NT-proBNP. That's what we're measuring, that inactive fragment. We also know that the active fragment is broken down by neutral endopeptidases like neprilysin. And there are drugs that inhibit that. If you've seen commercials for Entresto, all right, that's salcubitril, and that's an example of this. I think that this drug needs better study. We have some very small preliminary studies. I can tell you we studied a forerunner of this, acadatril, many years ago, and it wasn't effective in horrible heart failure, but it might be that we just picked the wrong patients. And Entresto is combined with an angiotensin II receptor blocker. But you can't treat based on a BMP. Mr. Marty here is a Chihuahua who is not in congestive failure, but has severe cardiac remodeling and also has a marked elevation of his NT-proBNP. So as we know from a number of studies, including the recent Hamlet study, which used a series of different risk factors to assess the idea that a dog had advanced mitral disease, or the older study, PREDICT from Penn, that looked at prediction of heart failure in dogs with mitral disease. The NT-proBNP will go up with progressive remodeling, and it certainly is a risk factor for heart failure, but you cannot treat based on it alone. Whether or not we will use it to show effective therapy, I'm not yet sure. Well, what are the common clinical outcomes of myxomatous valve disease? Well, I'd first like you just to read this quote from Michele Borgarelli's study, the DELAY study, which looked to assess whether or not RAS inhibition would delay congestive heart failure. And I think if you see that really low 6-year mortality, it shows you that you need to stage patients. You can't just take every dog, put them in they have mitral valve disease, and give them pimobendan category. That's just not the right thing to do. So we know that we can see remodeling both by X-ray and radiography. We know that some patients develop congestive heart failure, typically left-sided. We know some patients have pulmonary hypertension. Those patients who have really symptomatic pulmonary hypertension usually present with exercise intolerance or collapse or ascites. And we know that there are other complications such as arrhythmias, maybe bronchial compression. I don't want to argue about that today. We can talk about it in the Q&A if you'd like, and ruptured left atrium, which fortunately is relatively rare, but regularly encountered in emergency rooms. So we can see this outcome here. Again, it's just another 2D echo, a parasternal from the right on your left side and an apical view on your right side. I think you can appreciate the thick mitral valve at the asterisk. You can see a prolapsing tricuspid valve at the arrow. You can see both left atrium and left ventricle are markedly dilated. And I don't know if you can appreciate it, but the left ventricle is still contracting pretty well. Now, if you measure across that minor dimension, it's not going to measure normally, but it doesn't need to. I'll give you a Dr. Hamlinism, and that is if you have a really big ventricle, you don't need to contract very much to eject a lot of blood. And so just looking at minor dimensions probably isn't the right way to really assess heart size or function, at least as you get progressive disease. Now, one thing that's really important is we use remodeling currently to decide whether or not we will treat with pimobendan. Let me see if I can go back and make this work. There we go. Okay. There we are. Okay. So the worst outcome, other than sudden death, of course, would be congestive heart failure. And patients who have left-sided failure are not specific in terms of their clinical signs. They typically have increased respiratory rate and effort, and many of them will cough. Big dogs almost always cough when they get alveolar pulmonary edema. I know some people say coughing's not a sign of heart failure, but that's nonsense, really. Sorry, that is. Anyway, auscultation may show an increase in heart rate. At least you tend not to have a pronounced sinus arrhythmia. There should be a murmur that's prominent. And many times there's a third heart sound, so you'll hear this shh, duh, shh, duh, shh, duh. And that third heart sound gets confused as a second heart sound, but it's actually a heart failure sound. In terms of respiratory auscultation, we often hear loud bronchial sounds, and occasionally we'll hear crackles, especially if we listen really carefully. But of course, many dogs with lung disease, especially idiopathic pulmonary fibrosis, also crackle like crazy. The NT-proBNP would be elevated, but certainly in the emergent area, that's not going to be helpful unless you have one of the newer BNP analysis units, which I still think require some validation. Thoracic radiography is diagnostic. And many of you will probably do thoracic POCUS if you're working in an emergency setting. And here we're looking for non-attenuating reverberations, or so-called B lines, that indicate a fluid-air interface. And when your entire screen is full of those, there's a reasonably good chance in a dog with a loud murmur that that patient has congestive heart failure. And lastly, of course, we can look at the echo to verify that there's valvular disease, cardiac remodeling, and at least we get some estimate of filling pressures from this. So one of the things that I find really interesting are studies like this. So what we know in normal dogs from a number of studies is that most sleeping dogs have a respiratory rate of less than 25 per minute. And what we see with heart failure, as the lung becomes stiffer with edema or congestion, really, and we need to increase the efficiency of ventilation. So instead of taking deep breaths, we'll now take more rapid, shallow breaths, is that the respiratory rate will increase. And as the respiratory rate increases, this is an indicator that the patient may be getting congestion of the lung, which makes it stiffer, and then eventually pulmonary edema or congestive failure. A sudden increase in rate is commonly seen in acute congestive failure. If you look at the graph on the right, this is a study from EPIC. This is a secondary analysis. And these are the respiratory rates of dogs who never went into congestive failure in green, and the dogs who went into congestive failure in red. And you'll notice that at the far right of the x-axis, time 0, that's when the event occurred, usually congestive heart failure. And you'll notice that the rates stay pretty stable until that patient's just about ready to go into congestive failure. Then they start to become tachypnic, and then eventually they really become hyperpnic. And so having clients monitor home respiratory rate is one of the best things that we can really do to manage this disease. We can certainly document left-sided heart failure with the classic 3 features, which will be cardiomegaly. Now, this is an Afghan hound, so it's a very deep-chested dog, but that is a big left heart. We will look for pulmonary vascular prominence, ideally a big pulmonary vein, although that's sometimes difficult to see. And we'll look for pulmonary infiltrates that are compatible with congestive heart failure. And they can be widespread, especially in fulminant pulmonary edema. They will not just be perihilar, which is typical, but they'll often be widespread. Another clinical outcome of chronic valve disease is right-sided heart failure, and many of these patients will have pulmonary hypertension. Again, symptomatic pulmonary hypertension tends to cause marked problems with exercise and often will lead to right-sided failure, especially in a dog who has significant tricuspid regurgitation. The ascites is usually caused by some combination of TR and either pulmonary hypertension or the development of atrial fibrillation, which is very decompensating to patients with structural heart disease. You can see a tricuspid regurgitant jet on the top in color Doppler, and you can see a spectral recording from a different dog on the right. That dog on the right has very mild pulmonary hypertension. That's typical of many cases. Not every dog will have pulmonary hypertension. But once again, not all causes of pulmonary hypertension are the same. So before we jump into phosphodiesterase 5 inhibitors like sildenafil, I think we need to identify, is this caused by type 2 or class 2 pulmonary hypertension, left heart failure, in which case we will first treat the left heart failure, or is this due to pulmonary hypertension from pulmonary vascular disease or lung disease, more precapillary, in which case sildenafil might be more indicated. One tip-off is often the left heart is volume starved when it's type 1 pulmonary hypertension. And you can see that it's a negative prognosis to have right-sided failure. This study from Francois Series and Alfort just shows the marked drop-off in survival in patients who present with right-sided versus left-sided congestive failure. The ECG may show outcomes of ectopy, mainly atrial ectopy. So on the top, you can see atrial premature complexes or supraventricular premature beats on the top. On the bottom, you can see a patient in atrial fibrillation. Again, this is a very destabilizing type of heart rhythm. Ventricular ectopy does not seem to be as important in most dogs. I think some of the larger dogs will tend to have more ventricular ectopy, but at the current time, it's not a standard of care to do Holter monitors on every patient with myxomatous valve disease, even when they're in heart failure. The therapeutic implications, of course, of atrial fibrillation are that you may need to slow the heart rate. I think if you look at current practices, the main reason people use digoxin nowadays is for atrial fibrillation, to try to impair conduction across the AV node and slow the heart rate. And this usually has to be given with diltiazem, the calcium channel blocker, to get better heart rate control. So that's a big overview of the disease. Now I'm going to talk very specifically about some specific points related to staging, drugs, and therapy. So what we know is that this disease has a long course. If you look at the x-ray on the left and the right, it's about 4 years difference between the two. And so we don't want to start therapy inappropriately. We want to appropriately time both monitoring the patient at home, because we don't want to make a client anxious and make them do things that's unnecessary. And at the same time, we also don't want to start therapy too early or too late if we're trying to delay heart failure. So this is where the staging comes in. So there are 4 stages by the ACVM consensus panel. Stage A are simply dogs at risk, so every Cavalier who comes into your practice, every little old Chihuahua, all right? Stages B1 and B2 are dogs who have evidence of mitral regurgitation but have no clinical signs of heart disease or heart failure. These dogs are usually staged by clinical methods, their age, their weight, their auscultation, and by standard 2D and or M-mode echo. And these are the two views, the short axis view of the left ventricle and currently the short axis view of the aorta, although I really dislike this view, for staging the severity of disease. Now, dogs that have B1 don't just have normal hearts. It's amazing how many cardiologists still say that. The reclassification of B1 has been normal-sized heart or insufficient remodeling to begin therapy. So B1 doesn't just mean normal-sized heart, but you don't have a clinical trial to show you should start treatment. B2 means dogs have sufficient remodeling to begin therapy to delay heart failure, and currently the only proven treatment is pimobendan. Stage C and stage D are progressive degrees of congestive heart failure. Stage C is usually treated with standard drugs and therapy doses. Stage D are patients that become refractory. It's a little fuzzy between C and D, to be frank, and I'm not sure how important that is clinically. So this is how we stage by M-mode echo or 2D echo. You measure the left ventricular end diastolic dimension, but because it's body size related, you have to normalize it. While 0.294 is not the ideal exponent to normalize, it'd be better to use 0.32 to identify cardiomegaly. What we know is that if you use 0.294 based on the EPIC clinical trial, you will identify patients who can benefit from pimobendan therapy in the preclinical stage. And those are dogs with normalized dimensions of 1.7 or more. If you look at the left atrium, the dimensions that predicted benefit of pimobendan combined with the left ventricular and clinical criteria was a ratio of 1.6 or more of the aorta to the left atrium. The problem with this view, to me, is that depending on the patient and the way you obtain your image, that cursor goes across all different directions. You can see from the multiple arrows I drew how differently you might get left atrial size and ratios based on this approach. I've never liked it, but it's what was done in the study, so we all do it. So this just summarizes the criteria that would be used to begin treatment with pimobendan based on the EPIC clinical trial. So these are dogs who were older. They were small breeds only in this study. They had murmurs that radiated, so they were at least grade 3. Their 2D echo showed valvular disease and remodeling, sufficient that I just measured, 1.6 LA to AO or larger, and a normalized left ventricle of 1.7 or more. And they had color Doppler evidence of MR, although I think auscultation can suffice for people who don't have Doppler. VHS was another criterion, but a 10.5 measurement for VHS is a terrible criterion and shouldn't be used. The therapeutic impact is if they fulfill all the above criteria, you should probably start pimobendan. Notice that the dose is a little bit lower in range than the labeled dose, at least in the US. This is a study that showed prediction of heart failure in dogs who had very similar entry criteria to the EPIC study. This is Borgarelli's delay study. And what you can see here in the hazard ratio, so anything at 1 or any confidence interval crossing 1 is not going to be significant. But you can actually see the best predictor was actually the LV diastolic dimension in this study. The LA was a predictor, but it was weaker. And VHS was pretty weak. And notice that the values they used for optimal cutoffs were actually much different, much larger than the EPIC clinical trial. I don't think this invalidates the EPIC clinical trial, but I think what it does is it shows that there are probably certain stages where we could initiate therapy where we might get benefit even later, but someone would have to do that study. The alternative approach for practitioners who can't do echo is to do staging using radiography as well. And what we know from a number of studies is that when you have a VHS of less than 10.8, you're very unlikely to fulfill B2 criteria, so therapy should not be started. In contrast, if you're more than about 11.5 or in some studies 11.7, you have a much higher chance of having a benefit of pimobendan and of achieving B2 status. That would really be the requirement, the prerequisite for starting that drug. VLAS has also been used to look at left atrial enlargement when you don't have echo. A VLAS that is more than 2.8 to 3 probably correlates to at least a moderately increased left atrial size. And there are a number of papers that have looked at this now and trying to predict stage B2 by echo using radiography. This is what I talked about earlier. The study on the left by Peter Lord was in Cavaliers. The study on the right is from the EPIC data. And what you can see is that if you look all the way on the right on the x-axis where congestive heart failure or the cardiac event occurred, that VHS stays pretty constant for years until about 6 to 8 months before you start to go into congestive failure, at which time the rate of change in heart size goes up somewhat rapidly. And this rapid rate is something that veterinarians can catch if they do serial radiographs. And if you change your vertebral heart size by about 0.1 vertebral body per month, that's a pretty big change. And both in EPIC and in Lord's study, that's about the point at which more rapid acceleration of heart size occurred, and they were about 6 to 8 months out from congestive failure. To me, a dog with that kind of change in their VHS would probably correspond to a stage B2. Well, what about the drugs? I'm just going to give a really high-level view of the drugs that we use to manage myxomatous valve disease. So firstly, we have loop diuretics, furosemide and torsemide. I think we're all very aware of these drugs as having efficacy both for treating acute congestive heart failure as well as in chronic heart failure, preventing excessive volume retention. Torsemide is more potent than furosemide on a milligram basis, but more importantly, I think, has better absorption. So it tends to be used more commonly in stage D. Pimobendan is an inodilator. It's a calcium sensitizer inotropic drug, far more potent than digoxin. It's also a vasodilator, although I don't think we understand completely the range of vasodilation that occurs with this drug in our patients yet. We can inhibit the RAS system using ACE inhibitors like enalapril or benazepril. We can use mineralocorticoid receptor antagonists like spironolactone, which was originally classified as a weak potassium-sparing diuretic, and it is, but it's more commonly called an MRA now. And we can also combine those. There's only one product I'm aware of in the veterinary world that does that. That's Cardalis, which has fixed dosing of benazepril and spironolactone. We only use digoxin nowadays. I only use it in patients who are in AFib, and diltiazem is really used only for management of arrhythmia. Now, when we look about drug therapy, you can think about mechanistic approaches. And I know in this group, you guys are far better at mechanisms than I am. And I think that's important. These are targets for therapy. And that RAS fingerprint, for example, from Marissa Ames' study is just an example of how the RAS system is far more complicated. And there are probably different polymorphisms for genetics. Some have been shown in dogs. So that may influence the type of ways that we treat patients in the future if we can more customize their therapy. But currently, I think we still care about the major clinical outcomes. Did our patient live longer? Are there less unplanned hospitalizations and hence less euthanasias? How's the quality of life? What's the side effect profile? What's the cost effectiveness of treatment? These are things that matter most to clinicians and probably matter most to patients as well. So I think currently when you're looking at clinical trial data, the things on the right are what are most important for us, whereas the information similar to that on the left is more important for development and mechanistic understanding. We also have some drugs that are direct vasodilators. We tend to use these mainly in decompensated severe congestive failure. These are either venodilators or arterial dilators. There's very little clinical trial evidence for these drugs. There's some old data from Mark Kittleson on apresilene or hydralazine, for example, but overall, these are clinical experiences only. Nitroglycerin is mainly thought to be a preload dilator, a reducer. It pools blood away from the lung, but it hasn't really been effectively studied. Hydralazine, amlodipine, nitroprusside are potent arterial vasodilators with varying degrees of onset that can be used to unload the left ventricle in acute severe congestive failure or in patients with intercurrent systemic hypertension. And Revatio, generic Revatio or sildenafil is used mainly for type 1 pulmonary hypertension or precapillary pulmonary hypertension that is symptomatic. For example, here's a patient who has life-threatening pulmonary edema, and it's certainly going to succumb unless we're aggressive. And in this patient, we gave standard therapy in the hospital, but we also gave nitroprusside, and 18 hours later, you can see there was improvement, and this patient was released from the hospital. All right, well, what about therapy of asymptomatic disease? We have a number of studies, but if I don't want to bury the lead, pimobendan is the only one that's been shown to be effective in delaying congestive heart failure in small breed dogs, at least at this time. So these are some studies of RAS inhibition. The one on the left is the SVEP study from Clarence Cavart at Uppsala. And you can see there was no difference. So at the top left, at 100%, none of the dogs are in congestive failure. At the 50% line, 50% of dogs have reached the endpoint of congestive failure. And you can see there was no difference between enalapril and placebo. The VetProof study that Clark Atkins led on the right certainly had a trend towards benefit, but it was a very modest benefit. The effect size was only about 4 months, and it did not achieve statistical significance. So we do not really have strong evidence for using RAS inhibition. What about combined RAS inhibition? What we know is that there is only one study that's currently looked at both benazepril and spironolactone. None of these drugs tend to get tested with pimobendan in the preclinical stage, and as a result, we're not sure if they would be superior to pimobendan in delaying heart failure. And I think many of us believe that the doses used in these studies have been suboptimal. They might have done better had they chose higher dosages, because they would be tolerated by most dogs in the preclinical state. And then again, there are some papers looking at polymorphisms for ACE in dogs, and certainly this might be one other reason, maybe why Cavaliers could behave differently than other breeds, for example. This is the most recent study. This is the delay study I showed you earlier from Borgarelli's group. And this was a combination of basically Cardalis. It was benazepril and spironolactone. And as you can see from those Kaplan-Meier estimators, again, at the top left, no dog is in heart failure. And as you go down, they're achieving the endpoint, which is mainly congestive failure in these studies. And it just did not delay congestive failure. There was no benefit over placebo. There was possibly less remodeling. But again, we could argue whether the doses were optimal, and it was not tested with pimobendan. So again, pimobendan at this point is the only drug that's shown benefit, and that you can see here from the EPIC trial. So the green dogs are the dogs on pimobendan when they've achieved the criteria I mentioned earlier for stage B2. And the blue dogs are dogs on placebo. And this was a significant difference. I kind of eyeballed 2 and 3 years on the y-axis. Notice how long these studies have to go. And this is a very long disease. And we probably intervene at the wrong time. Probably if we intervened a little bit later, we'd probably see even more benefit, and it might be more cost-effective to clients. But again, we don't have those analyses. But there was fundamentally about a 14-month difference or delay in the onset of congestive failure between placebo and pimobendan, at least for median time in this study. And that's really what's established the treatment of B2 at this time. So lastly, how do we treat the patient in the hospital and in home when they have congestive heart failure? Well, using the same drugs that I mentioned previously, we can usually effectively manage them in the hospital and then give them a good quality of life for a reasonably long period of time. Much of it depends, of course, on the compliance of the client, the maybe aggressiveness of the veterinarian, and of course, to some degree, the patient. And there are so many factors that you all are aware of, including economic factors that influence outcomes. These can really affect clinical trial data as well when you don't randomize effectively or at least even consider the economic status of your clients, because euthanasia is usually one of the composite endpoints. See, we don't just have congestive heart failure as endpoints. We have euthanasia, we have sudden death that may or may not be cardiac, we have people giving the wrong drugs. So these composite endpoints create messier clinical trials. But obviously in our world, euthanasia is always going to be a consideration. And I think it's really important that we randomize patients well in clinical trials in order to deal with that aspect of it, because client perceptions will have a huge effect. And obviously university studies will probably be different. Specialty practice studies will be different than those done in the general practice, where the clientele might be more or less motivated. All right? Well, back to Ali, you've already looked at him, I'm sure. And you can see that baseline x-ray on the left, and this is his current admission, about 3.5 months later, because he's ruptured a chordae tendineae, and now he has acute left-sided congestive heart failure. Look at the difference in his vertebral heart size. Now, these are different magnifications on the x-rays, but I think you can appreciate that his VHS has increased dramatically from his baseline, and it's now up to about 11.3 or more even, depending on which view you took. And it was about a 0.2 vertebral body per month change. And the echo showed ruptured mitral cords. So how do we treat a dog like Ali? This is not Ali, but I'm sure they're related. And we try to give students, easy mnemonics to remember. So one I use is so fine for sedation, oxygen, furosemide, inotropic support, and extra therapy that might be needed. I realize that's not a particularly precise way of doing it, but it's what I tell my students. Most patients with respiratory distress will benefit from sedation, usually butorphanol and oxygen. So that's pretty standard therapy, even while you're assessing really dyspneic patients. IV furosemide by bolus or by constant rate infusion is usually necessary, most of the time by bolus. And the drug is very well absorbed, even IM and sub-Q if you can't get an IV. Pimobendin in the hospital, many of us will dose it 3 times a day in acute decompensated heart failure. That may fit its kinetics a little bit better, but then it's eventually dialed back to twice a day at the labeled dose. And then extra treatments sometimes are beneficial. I showed you that dog with fulminant pulmonary edema who received nitroprusside. That's an example of a direct vasodilator. I personally have my own tube of nitroglycerin that I walk around with because the hospital doesn't want to stock it. But if I had a patient who was dying of pulmonary edema, I'd rub a little ointment on his skin despite the lack of evidence. And then some dogs require synthesis, although that's not the typical patient with myxomatous disease. Well, here's Ollie's 7-day follow-up, and you can see his lungs look better. His heart's still huge. It has to remodel to accommodate that regurgitant volume from the ruptured cord. And he's doing fine. He had normal blood pressure and a normal renal panel. Now, in transitioning patients from hospital to home, obviously we're going to stop sedation and oxygen. We usually substitute injectable furosemide for oral furosemide, although in some locales, torsemide is now being used as a once-a-day treatment due to its long duration of effect. Pimobendin is continued at twice-daily dosages. If the nitrate was even given, it's of course stopped. ACE inhibitors and spironolactone are usually initiated either at release, especially if kidney function is normal, or at first recheck. I think cardiologists have different opinions about this, and they are concerned. We are concerned about renal function, although you usually will see some mild hypokalemia, hypochloremia, and mild azotemia in the acute heart failure patient after 24 hours of therapy, but that usually sorts itself out very quickly once the dog is feeling well enough to drink and eat. At recheck, we mainly focus on respiratory rate. I prefer sleeping respiratory rate, quality of life indicators such as appetite, interaction with the clients, ability to perform mild exercise. And we usually recheck a renal panel, electrolytes and renal function. We may or may not do radiography. If a patient's eupnic at home, sleeping comfortably, his respiratory rate's 22, he auscultates normally, I'm not sure an x-ray is necessarily helpful. And I don't do a follow-up echo. It doesn't change what I do unless the patient has signs of pulmonary hypertension. And then we adjust over time, and we may add medications. Chronically, we use dogs are for special people as a mnemonic, and this is really quad therapy. So this is going to be diet, which our next 2 speakers are going to talk about, ACE inhibitors, furosemide, spironolactone, and pimobendin. Now, those of you who are listening from, let's say, Europe might say, well, the evidence for RAS inhibition in this disease at this stage is pretty weak. Yeah, I agree. I think the problem is that we have a number of clinical trials, and there's not time to go over all of these different data. But I think if you put cardiologists together and ask them to evaluate all these different clinical trials, what you'll find is that many of them will say, well, this was a little bit deficient here, or this one had limitations there. In my view, there is no optimal study that's been done yet. These are all largely run by pharmaceutical companies. They have their own goals in looking at treatment, and it's not usually the goals that we all are interested in. We are certainly going to be aware of the economics and compliance issues. Again, there are studies that show that clients have trouble giving lots of medications, and you all know this as well as I do, that your effective prescriptions are only going to work if the client can actually give them. We may occasionally add in other drugs like digoxin or diltiazem for AFib. This is just an example of the study that allowed Cardalis to be approved by the FDA. And you know, again, look at the composite endpoint. Cardiac death or euthanasia or recurrence of pulmonary edema or necessity for a non-authorized drug, which was usually pimobendin, or a high dose of furosemide. And I mean, those are logical, but they're also messy. And if you look at the data, so if you look at the graphs over time, the dogs who received only benazepril didn't do quite as well as those who received combined RAS activation, which makes sense. But this is a very modest effect. And I think one of the problems is that you've got fixed dosing here. you have increased costs, so this drug is far more palatable and easy to give, especially to difficult to medicate dogs. So there's both pros and cons of looking at a drug like this. And there's no pimobendan on board, so we don't actually know if this drug would outperform Lasix and pimobendan by itself. It makes sense that it would, but again, we have this evidence where we usually compare one drug to another, but we never give the optimal combination of therapy. Okay, so my last couple of summary slides are, here we can see the standard quad therapy I think most cardiologists, at least in North America, tend to use. And again, this is a loop diuretic, pimobendan, spironolactone, and an ACE inhibitor, and that's really how we treat our patients. We're going to hopefully mitigate fluid retention, volume retention. We're hopefully going to protect against the injurious effects of renin-angiotensin-aldosterone system and aldosterone escape, and we're going to support the heart and its pumping function, and actually make it smaller. Drugs like pimobendan actually make the heart smaller and probably functionally reduce how much mitral regurgitation is present by bringing the annulus together. And here's Ollie 2 years later. He's still alive. He still has calcification in his biliary tree, and he actually lived almost 3 years. Now, that was mainly due to the diligence of him and his owner. Last few points, stage D dogs, they can develop pretty severe ascites, and these dogs, we usually need to change therapy. Obviously, abdominocentesis will take pressure off the diaphragm, but in this case, we're commonly going to switch to torsemide if they're not already on it. Not that torsemide is necessarily more potent, it is on a milligram basis, but its absorption and duration of effect, or duration of action, are greater. And so this is a very common strategy that cardiologists will use. There are other strategies, including other diuretics or subcutaneous injection of furosemide a few times a week. And some dogs will diurese quite vigorously when torsemide is added, and as a result, you need to get them back pretty quickly to assess their renal function. Just to look to the future, Dr. Ieki in Japan has been repairing mitral valves for a really long time. And this, of course, is a very niche, highly expensive treatment. But I showed you this slide on the top at the very beginning. And what you're seeing on the bottom is one of his drawings showing an annuloplasty to bring the valves closer together. And then I also showed you the slide on the bottom at the beginning. And this is a diagram on the top of Dr. Ieki's technique for repairing ruptured cords and for making the mitral valve not prolapse as much. Most of his dogs go off therapy. So it is certainly possible, if you can afford the great cost and the cardiopulmonary bypass and the travel, to have effective surgery of the mitral valve. But currently, this is not really practical for very many people. And then lastly, we can talk in the panel discussion about any future directions, if you will. There are different devices that are being developed. For example, on the right is a diagram from Lou, who used a TEER, or a transcatheter edge-to-edge repair of the mitral valve, pulling the two leaflets together, basically. It creates a little mitral stenosis, but amazingly, it works to reduce the amount of mitral regurgitation in people and apparently in dogs. There are a number of centers that are looking at that right now. Colorado State has a device. There are other institutions. Bristol has a device. There are other schools who are working with different devices in order to try to reduce the mitral regurgitation in a minimally invasive way. And lastly, we don't treat humans exactly the same way we treat dogs with heart failure. There are certainly some differences. If they're interested in that, I can discuss that over the panel discussion. Thank you very much for your attention. Thanks so much.